Exactly.
It's a real pleasure today to introduce
One of each. He would be shocked.
Sorry about that. Welcome to today's DCRI Research Conference. It's a real pleasure to introduce Dr. Michael Merson, who is the founding director of the Duke Global Health Institute here at, and as well as the Wolfgang Joklik Professor of Global Health at Duke University. He joined the faculty at Duke in November of 2006 and was named Vice Chancellor for Duke National University of Singapore Affairs in March 2010. Most recently, he was also named the Interim Vice President and Vice Provost of Global Strategy and Programs at Duke University in 2011. I'm going to give a long, embarrassing introduction to Dr. Merson because I've really grown to like him a lot. He's a sage person with tremendous experience. And so I just want to highlight a few things. He graduated from Amherst College and then went to SUNY Downstate Medical Center, serving as a medical intern and resident at Hopkins, and then worked at the CDC in the enteric diseases branch. He then served as the chief epidemiologist at the Cholera Research Laboratory in Dhaka, Bangladesh, where his research focused on the etiology and epidemiology of acute diarrheal illnesses, specifically cholera, as well as traveler's diarrhea in persons visiting these countries. Then in 1978, he joined the World Health Organization as a medical officer in the Diarrheal Diseases Control Program. He served as the director of the program from 1980 to 1990, and in 1987 was appointed the director of the WHO Acute Respiratory Infections Control Program. And then in 1990, he was appointed director of the WHO Global Program on AIDS. And if people think back to that time, this was a really pivotal time in the fight against AIDS. This program was operational worldwide and responsible for mobilizing and coordinating the global response to the HIV/AIDS epidemic. Then in 1995, he joined Yale University School of Medicine as its first dean of public health, as well as professor and chairman of the Department of Epidemiology and Public Health, positions he held there until 2004. From 1999 to 2006, he also served as the director of the Center for Interdisciplinary Research on AIDS at Yale, which undertakes research on HIV prevention in vulnerable and underserved populations in this country, as well as leading programs across the world. He's authored more than 175 articles, primarily in the area of disease prevention. Most recently, his contributions concern HIV policy and prevention in developing countries and broader global health issues, some of which we'll hear about today. He served in advisory capacities for a number of organizations, including UN-AIDS, WHO, Global Fund to Fight AIDS, TB, and Malaria, the World Bank, the Doris Duke Foundation, the World Economic Forum, and the Bill and Melinda Gates Foundation, as well as a number of NIH review panels and advisory committees. Finally, he's also received numerous commendations, including 2 commendation medals from the United States Public Health Service, the Arthur S. Fleming Award for Distinguished Government Service, the Surgeon General's Exemplary Service Medal, and 2 honorary degrees, as well as being an elected member of the Institute of Medicine. Please join me today in welcoming Dr. Merson.
Sorry for that long introduction. Thank you, Uptel. So I haven't been here, I think, in at least 5 years, and I did speak here maybe 5 years ago, and lots happened in global health, and a lot's happened in the Institute since then. So Uptel asked me to give a talk. I think he saw something I wrote in the New England Journal of Medicine on university engagement in global health, so I made that the title. But for me to make sense of that topic, I need to first bring you quickly up to date on what's happening in global health so that you would have a little bit of understanding of why universities are involved and how universities. So it's sort of 2 lectures in one, but I'll do my best certainly to keep to the time limit. So this is a definition in global health which a number of us wrote. Actually, the lead author on this was from Emory, but we put together this definition back in 2009 in The Lancet. It's long, but it's meant to emphasize the field of a study. It's a field that covers, obviously, study, research, and practice, and it emphasizes transnational health issues, determinants, and solutions, many disciplines. It's very interdisciplinary, and I'll show you that in this talk, and a synthesis of population-based prevention and individual-level care. That's a broad definition. I'll try to make it real. Let me first, though, talk about in 2 slides all the health problems in the world and put some perspective on the field of global health. So this is the latest WHO data, and we all know WHO data is what it is, but it is as good as we can get. And this is from 2012, and this just shows you the leading causes of death in the world. And this is not a surprise to any of you: heart disease, stroke, lung disease, chronic lung disease, pneumonia, AIDS, diarrhea, et cetera. And this is the world as a whole. But if you look at what's happening in the world by low income in blue, and then lower middle income, and then upper middle income, and higher income in these colors, what's interesting, and this is again 2012, but it's not much has changed, but you can see that, of course, that these diseases of heart disease and stroke are both categories of middle income and high income are the leading causes of death. And it's only when we get to the low-income countries that we start to see a considerable amount of deaths due to AIDS, and that's changing. I'll show that in a minute. Diarrheal disease, pneumonia, and here. But even in the low-income, there are quite a bit of deaths from the more chronic diseases. So that's and in fact, as I'll show you in a minute, that's the trend of the world right now. That is that the common causes of death and disability are becoming more and more the same wherever you go in the world. And I think that's a really critical point for thinking about global health. So I'm going to just briefly cover here 5 key, what I call crossroads issues in global health today that I think set the framework for what we're thinking about in the field. And I've listed them here. The first one is the unfinished agenda. So what do I mean by the unfinished agenda? So some of you may know the Millennium Development Goals, and this is something certainly all our students know. These were goals set in 2000. They end in 2015. There were 9 goals set in the United Nations for development. And what was interesting at the time is that 3 of them, 4, 5, and 6, were health goals. Remember, these are development goals. What's interesting is that 3 of the 9 were health goals. And it's interesting to look at these because these have been closely monitored, and we're now at 2015, which is, we're soon going to have something I'm not going to talk about called Sustainable Development Goals. They're going to replace the Millennium Development Goals. But how have we done? And this is the unfinished agenda. Obviously, we're in 2015. Have we met these goals? And if we haven't, we have to finish meeting them. And so the 3, we can look at 4, 5, and 6 quickly. 4 is reducing by 2/3 under 5 mortality. That was the goal. And in fact, we've reduced it, you can see here, from 12.7 million deaths to 6.3 million. So we've made good progress in reducing childhood deaths, but nowhere near meeting the 2/3 goal. And the big issue here, of course, is neonatal mortality. This is where we've made the least strides. It has to do, of course, with the causes and then, of course, the treatment of neonatal mortality, which requires a sophisticated health system, which doesn't exist still in a lot of parts of the world. But reasonable progress on child mortality. The second one was maternal mortality, and here we've done, unfortunately, much worse. It's only gone down 22%, and we had hoped to reduce it by 3/4. And this is primarily because of the number of maternal deaths that occurred during childbirth, primarily in sub-Saharan Africa. Many of these births occur in the home, and we don't have ways of dealing with the complications of pregnancy in the home. Many of you know what those are. They're no different wherever you live. And so I think that this is where still we need a health system that's really functioning around in the poorest countries of the world to do something about maternal mortality. Then if we look at goal 6, this was, remember, the infectious disease goal, HIV, AIDS, and TB. So with HIV, of course you know this very well, that we still have 35 million people living with this is 2013 data. But of course we have those people because people are living now with antiretroviral drugs. And the big progress has been that the number of deaths is down, in 2013, and it's going to get lower to 1.5 million, which is a 35% decrease since 2005. So we've made enormous progress, and we're going to make more progress on AIDS. And with malaria, and this is sort of a crude slide, this is putting a lot of data together from the International Health Group in Seattle, and you can see this is a whole bunch of data from 10 different data points. But what you can see is that 30% reduction in malaria deaths in Africa from 2004 to 2010, and a 25% reduction in children. And most of this is bed nets. And the more we can get people on bed nets, kids under bed nets, the less disease they'll have. Insecticides are now being used again. Many of the drugs work. We still have pockets of resistance you probably know about. But we are making progress in malaria, not as much as we've made in AIDS, but we've made reasonable progress. So that's number one. That's the unfinished agenda that is critical for the future. The second area, well, that just shows you the graph, is what is clearly the future of global health, and very much in the DCRI area, and that's the global burden of chronic disease. And I don't have to tell this group about that, but I'll just mention a few things that you may find interesting. They're the leading causes of death globally. In 2010, 2/3 of deaths in the world attributed to NCDs. What you may find interesting is 80% of deaths and 90% of early preventable deaths are in low and middle income countries. I showed you that in an earlier slide. And the third one is particularly interesting to me. 25% of these deaths are in people less than 60. So I have a number of colleagues, particularly in urban Africa, in their 50s, 40s even, 60s, dying of stroke and heart disease, myocardial infarction. Reminds me of my father's generation. If you think back in this country where we were, 20 years ago or 30 years ago, that's what you're seeing now. And when these new chronic diseases come into a population, they often kill people in their 50s and 60s. And that's what Africa is facing now, not just Africa, but more and more of the lower income countries. And then, of course, we expect a 50% increase in them as a share of total deaths by 2030. This is an interesting graph because it shows the disability-adjusted life years. So this is a combination of mortality and premature morbidity. We call that DALYs, disability-adjusted life years. Every field has its abbreviations. So what's interesting here is you can see, not surprisingly, the light blue and the dark blue, cardiovascular disease and cancer. As you get older, you would expect that to be, and this is just low and middle income countries now. So you'd expect most of the DALYs to be there. But I want you to look in the early years at the yellow area. That's the 1, 2, 3, 4, 5, 7th color. And that is mental and behavioral disorders. And what's recently been recognized is the severity of mental illness in young people in low and middle income countries. And I mean, we can go into this in depth, but it's not so different than in other countries, with suicide being an example, the huge rates of suicide, for example, in India. And so this is just an interesting phenomenon. So another chronic non-communicable disease that's getting more and more attention now is global mental health. Now, of course, not a surprise. Why are we seeing this big increase in chronic diseases? The good news, I guess, is that this year, for the first time, there were more people over 65 than less than 5 in the world. And you can see that here. The green is now coming over the blue. So obviously, we are having an older world, and wherever you live, so we're going to have more chronic disease. Now, I had to show this because I'm in DCRI. This shows the percent of people with hypertension in the world. And I don't know if you all realize this, these are the WHO regions at the bottom here. So Africa, America, Eastern Mediterranean, Europe, Southeast Asia, Western Pacific, lower income, middle income, upper middle, or high income. It doesn't matter how you want to look at it. And this is by men, women, and both sexes. But I want you to realize that pretty much anywhere you are in the world, 40% of people are hypertensive. And that's, take the lower income, it's even over 40%. So hypertension, if I had to pick one chronic disease more than any other in adults, certainly hypertension, and accounts for some of that early mortality, and most of this, of course, is undetected. Much of it is undetected. Diabetes, another one. This is global diabetes prevalence in the world. This is very recent data from the International Diabetes Foundation. So you can see here, in most of this in the Western Pacific is China. That's about 10% of the population. So about 10% of China has, if you just take China, are diabetic, or will become full-blown diabetic. You can see the highest rates. Well, this doesn't show you rates, but the highest rate, this is prevalence, 9.7% in the Middle East. They probably have the highest rates in the world in the Middle East. So it's interesting what a huge problem diabetes is. Again, a lot of this not recognized early in illness, but for those interested in diabetes, there's a huge research agenda in low and middle income countries. This is cancer, and this is the one slide I want to show you about cancer, which, again, you probably know, but people often tell me, well, you can't do anything about cancer in poor countries. Well, this is just showing you the difference in the number of new cancer cases attributable to infection between less developed and more developed countries. And you can see that we know that about at least a sixth and maybe more of cancers in low-income countries are due to hepatitis B and C, papillomavirus, helicobacter, and other infections that can be prevented or treated. And as many of you know, we soon hopefully can eliminate hepatitis C through treatment all over the world. And there's a movement on there now. Actually, Andrew Muir is involved in this. He's on his way to Burma today as part of a project we're doing with the Clinton Access Foundation, trying to figure out how we can actually treat hepatitis C in very poor countries using very reduced price drugs. So we can do a lot for cancer just by approaching it from an infectious standpoint, no less more complicated approaches to cancer. And of course, the major risk factors are smoking and eating. This fellow's just finished exercising and he's having a cigarette. But of course, we know that in Asia, many of you have been there, 70 to 80 to 90% of men smoke, and this is a huge risk factor. And of course, diet is a big issue. I'm not going to go into that. The third issue, again, thinking of the future and where we know we need to have a priority in global health is what is often termed universal health care. Now, I'm not going to try to define it. Please don't ask me what it means. But I will tell you that there is a group that's working here. This is from The Lancet, from Richard Horton, put a paper in The Lancet. He's the editor, based on data mostly from the World Bank and WHO, trying to come up with indicators of universal health care. One is access to quality health prevention and treatment services. The other is access to safe, effective, quality, and affordable medicines and vaccines. And then the other is financial risk protection coverage against poverty and catastrophe. Health shocks are a major priority in low and middle income countries. One illness can put a family into poverty forever. Now, actually, we see health shocks in our own country. We don't talk about it, but there's plenty of evidence of health shocks in our own country. But I don't know how we would do on these indicators, but I think the idea of universal health care is that we'd be committed to the least well-off from the beginning of the journey. So the idea here is we'd focus on universal health care with the poorest nations first. And of course, if we do that, we can have an impact, as I already mentioned, on such issues as maternal mortality and neonatal mortality. Okay, the fourth issue I want to mention is setting the stage here for what is priority for global health is what I call new threats. And as I'll show you in a minute, it's the new threats that drive the money for the field more than anything else I've mentioned. So what do I mean by new threats? Well, the obvious one are the emerging and re-emerging infections. And I'm not going to try to go over this graph, but this is a graph which goes back to 2004. I don't even think we could make it now. But this just shows you every year since about 1980, there's been either a new organism discovered or an organism that has re-emerged, that has become a threat because we don't have antibody for it, or we don't have a good way to treat it. We don't have a good way to prevent it. And most of these, 2/3 of these are viruses which have mutated from animals to man. And this has born a whole new field called One Health. We have some outstanding faculty in our institute working in this field of One Health, which requires interaction between, obviously, epidemiologists and clinicians, veterinary public health individuals who are interested in diseases in animals, and the people interested in the environment, because the environment plays a large role in the transmission of things like avian flu, which has become, as you know, in something like 40 states in this country right now, a real threat. Not to humans, but it could certainly mutate to humans. So that's, and of course, the one, you all know, the big one the past year has been Ebola, with 25,000 people infected and over 10,000 deaths. This is just the latest. It's not the end by any means. I'm still mostly worried about flu, as that to me, I mean, imagine this disease. The nice thing about Ebola, nice thing I guess is not the right way to say, but the nice thing about Ebola is that you were sick before you could transmit. So this was not a high-risk disease. In terms of, if someone was sick and you could quarantine them, or you could they weren't going to transmit. But with flu, as you know, you are transmissible way before you get sick, at least a day. And that, to me, is really frightening compared to a disease like Ebola. So, but it is the latest of our threats, okay? The other threat, which you know much more about than I do, is this whole antimicrobial resistance storm, which this is a slide that shows that there were 18 companies working on antibiotics, and in 2011 there were 4. So we have a real dearth of new antibiotics. Many of you know more about this than me. And we have these new strains of methicillin resistant, vancomycin resistant, Enterococcus fluorochrome resistant Pseudomonas. They're rising. You deal with this. Some of you are clinicians. I think there's now, in the last few months, more attention to this. There's a new fund that's been created to create new antibiotics. Some of the pharma are getting a little more interested in this. But this, to me, is another threat. A little kind of a different threat. There was a recent paper I saw in, I have no idea how accurate the data is, but this was from Nature, and it showed that there could be, in 2050, as many as, what was it, I think 30, how much was it, about 300 million, yes, people killed by 2050 by antimicrobial resistance. I'm not validating this data, but it just points out the potential severity of the problem. And notice a lot of it in Asia and Africa. That's what I found interesting about this analysis. Okay, now I mentioned this already, but this is the graph showing the amount of development assistance for health in low and middle income countries from 1990 to 2013. And I want you to see it's about $30 billion. And it's stayed about $30 billion now for a number of years. And even during the downturn in 06 and 07, the number still went up. So this is a very substantial amount of funding available for global health. And the sources of this money is very varied. I mean, you have the US here. I'm just showing you on there the purple. We're one of the major ones. But you have other bilaterals as you move up. Blue is WHO, then light blue is UNICEF. The Global Fund is in purple. The NGOs are in light green, the World Bank in sort of a yellowish green and in orange. So you see that there's a wide range of money coming into the field. This is why our students are so lucky to be able to often find jobs, because there's a lot of money in the field of global health. But if you'd say to me, what's driving it? What's driving it is this issue of threats. I mean, Ebola got $8 billion out of the Congress. Tell me one other thing that's been able to get bilateral support out of our Congress this year. Probably not much more than Ebola. And this just shows you the U.S. global funding from this is through 2 presidents, and you can see that we've kept it around $9 billion. And again, this is both Democrats and Republicans. And tell me one other issue where they agree. This went through in one day, this legislation. So it's interesting to me that if there's one area politicians both agree for different reasons, maybe, global health maintains, but it is the threats that are driving the agenda. And then lastly, to set the stage for what we do in academics, is what I call the New World Health Order. It's a bit of a dramatic title, but just to make the point of what's changing in terms of who has the authority, the power, and the money. And I think what's interesting, this is a graph that only goes out to 2010, but the point I think is well made. This is the absolute GDP growth in the BRICS. So what are the BRICS? You all should know about the BRICS. Brazil, Russia, India, China, and South Africa. These are the middle income countries that all have a substantial growth rate, with China, of course, off the map in terms of their GDP. But I think in 2 years, China will become a donor. I think in 5 years, India will become a donor rather than a recipient country. And they have formed their own development bank outside the World Bank, and they are becoming more and more funders of global health research and global health programs. I can tell you our institute has opened a global health research center in China. We have enormous amount of support coming from the Chinese government and from other institutions in China. We don't need to look to the US to fund what we're doing in China anymore. And I think the other point here, the largest bilateral donor by far, to health in Africa are the Chinese. And so we have to learn to live with the Chinese in particular, but not only the Chinese. All of these countries are critical for the future of global health. So that's one change in the New World Order. The other change, and this is not the easiest graph to read, this just shows you how the urban, this is a McKinsey graph, showing you what are the richest cities in the world in terms of GDP. So the top 50 cities in 2007 and 2025 are in light green. You can see they were the top economic city in 2007, and they will also be in 2025. The light color, and that's what's hard to see here, but you'll see some in the US. There are some just with no color inside, circles. They were in the top in the top group in 2005, but they're not in 2025. And the dark bluish green, those are the ones newly in the top group in 2025. So this is no question where the economic cloud is. And the implication, of course, is that's where industry is, that's where a lot of excellent research institutions are, and this is where a lot of the future discoveries and work will be done is in Asia. And it's not only Asia. I don't mean to say there won't be anything left in the US and Europe, but you can see more and more of the cloud is moving to Asia. So I consider that, in terms of our thinking about global health, part of the New World Order. DCRI will soon have offices, I presume, in a lot of these cities. Then, of course, another part of the New World Order is the absolute need for a leader. You all know that the reputation of WHO could not be worse. I don't have to make a case for that. The Ebola outbreak was just a pure failure of WHO. It's an organization I worked in, as you heard, for many years. It was much different then. It was an excellent organization then. I was proud to be there. I would never recommend anyone to work there now. And this is a very nice report. If you're interested on what's gone wrong, you can read it. It's a Chatham House report. You all know the Chatham House in the UK. But more important question is, what now? Who is going to take the lead in global health in terms of political and policy leadership? This is a critical question for the New World Order. Can WHO fix itself? I'm doubtful. If not, who takes over? And how do we make it work? There was an interesting editorial 2 days ago in the New York Times about going back to the Bretton Woods conference in the late 40s that created the UN, and rethinking a lot about what we did 75 years ago and how relevant that is to the world of today and the world of tomorrow. But if you're in global health, this is a big issue. Okay, so that just warms you up to a little bit about, now you're all experts in global health. So what do we do academically? So of course, given what I've told you, there's been a huge interest in the field. And this just is some data, and unfortunately, this data hasn't been collected since 2011. But these are North American universities with significant global health programs. And significant meaning it involves at least 2 schools, it has research, it has education, and it's overseas work, not just a course. But something, and the latest data I have, but it's anecdotal, is this number is about 115 now. So there are about 115 universities with serious major programs in global health. This is the same data from 2011 when they did the survey. They found that 250 universities, this is done by our consortium of universities of global health, 250 universities had some global health activities, 70 had global health centers, that was the graph I just showed you, 49 had offered degrees of some kind, 21 did not, 22 universities without global health centers still had offered degrees, and 150 universities had something. So all told, that's 250. My hunch is now 300 universities have something in global health, of which about 120, 125 have something really substantial. It's interesting to see a field grow so quickly in a period of, say, 10, 15 years. And for people like me who started, I first went abroad for health in 1969. It's amazing to see what's happened. And a lot of this has been driven, frankly, by students around the country, and not by faculty as much as by students. Now, some faculty, but I mean, we had a Ralph Corey, and we had people that had been here on the forefront decades ago. But what's really driven this kind of movement, and if you want to change something at a university, faculty can't get it done, but students can get it done, and that's what we've seen at university after university around the country. So this is the New England Journal asked me last year to put together a paper on university engagement in global health. So I surveyed and talked to a lot of people in the field and tried to put something together that represented a consensus of what I thought was happening across U.S. universities. And I sort of divided it up into 6 areas. And we could cut this cake different ways, but it seemed to me this was one way to cut it. So I'm going to quickly show you these and then tell you what we're doing at Duke. And because I don't have time to, I visited a lot of universities and have a pretty good sense of what's happening around the country. But I think Duke is an example, and we know it, so we might as well talk about it. So the first is education. And I think the critical thing here is utilizing interdisciplinary curricula to solve world problems. So it's a field that is very directed on problem solving. It's a field that integrates perspective from numerous disciplines and specialties. It involves work with communities, and I must say that what I've seen that global health has done is it's helped universities create environments to support interdisciplinary collaboration, develop new global health educational models, I'll show you in a second what we've done at Duke, and providing distance learning technologies, which have been very much accelerated by global health courses. So I'm just going to quickly show you education at Duke, some of the things that you may not know, you may know. 3 years ago, we started a major, an undergraduate major. We had no idea what would happen. And we're now at the end of our 2nd year, going into our 3rd year, we actually have 304 undergrads that have signed up for our major or minor. This is remarkable in such a short period of time. And what's interesting about this major at Duke is you have to take it as a co-major. So these are undergrads at Duke that have signed up for a global health major, but they can only sign up, and we thought it would keep the number small, if they have a 2nd major, but not Duke. It turns out 70 to 75% of undergrads today either take double majors or a major and a minor or some other combination. Only 20% of Duke undergrads take just one major. This is a phenomenon that, I don't know, it was news to me. But what I want you to see is all the co-majors. Look at all the list of the co-majors that they're taking. It's not just biology, pre-med. It's a whole list of things, Russian, Spanish, history, African-American studies, economics, environmental science, evolutionary, a very interesting mix of our undergrad. That's the future of global health, that you see this kind of enormous interest in undergrads. Now, we also have a master's program, which we started, a Master of Science in Global Health. We take about 35, we're up to about 35 students a year. Half of them are international. And what's interesting about this is all of these universities, so Baylor, Cornell, George Mason, Georgetown, Harvard, Northwestern, Berkeley, UCSF, Notre Dame, and USC, all have started Master of Science in Global Health in the last 10 years. So we thought we were onto something new. There wouldn't be that much competition. There's plenty of competition. Okay, and there's going to be another 10, I'm sure. And this is, I don't have time to go into it. This is not an MPH. It has some elements of an MPH, but it's very much focused on research outcomes, doing a thesis, and it's very focused on global work. And they have become quite popular, and these are all the universities that I know have them now, and I think there are some in the works. So undergraduate masters. Now, of course, medical school, we have at Duke. I've talked to a lot of my colleagues who can't get 5 minutes in the curriculum. We were lucky, as you know, there's nothing more valuable in a curriculum than a medical school curriculum. 1 minute is worth gold, right? So people fight for 1 minute in the curriculum. So we were able to get a week in the 2nd year, and we do this in combination. You can see this is the week and what's covered. This is what we did last year. The red is global health, and we intermix it with health policy. So they did a joint week together. Dennis Clements has been running this, and we're trying to figure out how to keep the students' interest for a week. But it's been fun. The other thing, which the Hubert Jürgens Center has been running now since 2008, is a fantastic, now other universities have it, but I think in our case it's quite unique to have this program, what we call Global Health Fellowship and Residency, Global Health Pathway for residents and fellows. You can see we've had 28 trainees, including 5 that just started from 6 departments, and none of them have gotten Fogarty Awards and they've written papers. And of 16 of the 28 have graduated, 6 of the 16 have stayed at Duke. 5 as faculty, 1 as a fellow, which is pretty good. So this is very much the future of medicine in global health, is this global health residency, or fellowship, where you take, you get a free You don't have to pay for a Master of Science, our degree, and then you go abroad and do a project. It varies in time, but let's just say 6 to 9 months, mentored by a faculty member, and Nathan Thielman and Cynthia do a wonderful job of running this program. So that's what we've done in medicine. Now, most of the other universities that do this don't have such a wide range of departments. Now, we also have an opportunity for residents to go abroad for 3 months that Ralph Corey's been doing for years. There are about 80 universities that now do that. They give these short-term experiences for residents. But I think very few do this as well as we do. And then, of course, there's a huge interest in doctoral students. And what we now have is a Global Health Scholars Program where we allow each year 2 doctoral candidates from across Duke. Doesn't matter what you're getting your doctorate in. You can become a doctoral scholar with our institute. We cover 50% of your stipend and a dissertation grant. And that allows you to do your thesis abroad. We have incredible applications. We must have had 15 applications this year that we wanted to fund. We just didn't have the resources for it. I think you can see where the students come from: environmental policy, environmental health, public policy, engineering, clinical psychology, and I think this year we took 2 from economics. We also have a doctoral certificate program. We have a lot of pressure on us to create a doctoral program, and we just don't have the ability right now to do that and the resources, but I am impressed by the enormous interest in doctoral students from many disciplines in wanting to get into global health, which is really great. A lot of that coming from their interest as undergrads. If you think about the double major, not everyone goes to med school, right? So a lot of them go on to get PhDs, and they want to maintain their interest and get their major in another discipline. Then I mentioned we have something called the vertical integration model. There's a very large $50 million gift that Duke got from the Bass family, which has been used primarily to set up these vertical integration teams. There are 5 themes. One of them is global health. We now have 20 of these teams. And you see that they involve postdocs, doctoral students, master students, and undergrads. And they go as a team to an area and do a research project under the mentorship of a faculty, funded by the Bass money. This is called vertical integration. It's been very popular with students to go out and do projects together with students that are either below or above you in terms of their training. And a few medical students and nursing students have participated in this. And they also have a number of activities there shown in green. Okay, I'm watching the time. So the second area is research that I mentioned. And here, most of the research is translational research, population level, determinants of health, reflecting the global burden of disease, which I mentioned early on, and requiring collaboration with researchers from different disciplines. So we in the Institute, and I don't have time to go into why we did this, but we have decided to focus on 7 areas. And we've been focused on these same 7 areas from the beginning. And they are cardiovascular disease and obesity, global environmental health, emerging infections, global mental health, global cancer, health system strengthening, and maternal and child health. These are our 7 research areas. And you can see here that over time, this shows you the distributions of the project. So cardiovascular disease and obesity, 62, 50, dark in the blue on the right, light blue, global mental health, 52, the red here, 62 is emerging infections. So we have and then the orange is health systems. We have less in global mental health because it's new, global environmental health because it's new, and then in cancer, we have not yet had a huge interest in our cancer faculty in working abroad. This is certainly something Nelson Chow, who leads this effort, is trying to do. I think it's going to take some time. Our faculty are leading 300 research projects in 54 countries. The countries where most of the research is going on are in blue. So you can see that the vast majority of the research is in East Africa, parts of Asia, and is in yellow. So most of our research is in East Africa, a lot of Asia, and a lot of South America. This is where a lot of the research is going on. Now, I don't have time to go into the research, the individual projects, but since I'm at DCRI, I had to list some of them. So emerging infections, we have an enormous amount of work going on in Sri Lanka, Tanzania, Congo, mostly related to emerging pathogens. Chris Woods and Greg Gray, who we hired this year, John Crump, who is involved in Tanzania. A lot of this is with our group in Singapore because you can ship specimens in and out of Singapore. We have a wonderful emerging infections group there in our med school. They do a lot of the lab work, even the specimens from the Congo we ship there. and it's much easier than shipping them anywhere else. And then, of course, we have a number of cardiovascular projects. I just listed them here. Heart disease in Kenya with Jerry Bloomfield, right side of failure in Peru with Melissa Burrows-Pena, metabolomics in India with Swati Shah, Malaysia and Ghana with Shailing Tang, John Stanifer, kidney disease in Tanzania, and Sarah Neal and obesity in children in northern Mexico. This is just a snapshot. Okay, our third area is innovation. This is one that's really taken off. This is this idea of cultivating innovations, technology and service programs, working with entrepreneurs, and I could talk the rest of the talk just about all we're doing in innovation. One project that is quite well known is this. We got a very large grant from USAID, $10 million grant and another $2 million supplement. This is to really scale up entrepreneurs, now 35 different entrepreneurs around the low and middle income countries who have health systems, and try to help them go to scale. And you can see we work with a lot of parts of Duke here. Well, these are all different Duke entities. And what we do is we identify high potential global health enterprises. We help them scale impact. We stimulate and catalyze impact investing to them. We have a lot of students and faculty engaged in this, and we generate and disseminate knowledge about the results. Again, I don't have time to go into depth. The second example of what we're doing, and Eric isn't here, I don't think, but Eric just recently visited this new institute in Amsterdam, AT, which is the Amsterdam Health and Technology Institute. This is an institute on health and technology that was started at the University of Amsterdam with money from the city of Amsterdam. We're the partner in this, and we work in three areas. We're developing training courses, educational degrees on this interface of health and technology talent. We are doing a lot of building a research and innovation portfolio with a lot of money from the European Union. And we're starting a number of programs on entrepreneurship. People that want to become entrepreneurs. How do you become an entrepreneur? How are you successful as an entrepreneur? And to do a lot of this, we're setting up a network of living labs, which is a term I didn't know before. These are living labs that are populations where you study in particular innovations. So if you want to study an innovation for senior citizens, you go to a population of senior citizens and you study the innovation. It's not a cohort. You study an innovation in a particular population depending on what the innovation is. And right now we're thinking of 4 labs, one in Durham, one in Amsterdam, one in Western China, which is very interesting, very poor areas of Western China, and one in Kenya. So these are 2 examples of what we're doing in innovation. We also have 6 centers. One is, the 5th one down there is the Digital Health Science Center. This is one that Gary Bennett just opened. These are 6 centers within the Institute. And it is really focusing on the science of digital health. I can't tell you how much this has taken off in low and middle income countries. I was talking this morning with a group that works in Kenya called Farm Access. They now have in 1,300 clinics, and I wrote this down because I wanted to remember, serving 500,000 people in Kenya. They now are using smartphones to both give healthcare messages, deliver information on treatment, and also to pay. They put in this new payment system that you can use, electronic payment, all in one go. I mean, it's fantastic what this electronic world is doing for healthcare. They are far ahead of us in using electronic media for delivering care. They told me that Pfizer has just offered them $5 million to buy up their system, which I found quite interesting. I told them it was cheap. They should ask Pfizer for more because they'll easily make that up with no problem. Then the 4th area is capacity building, and here I would just say this is strengthening our partners. This is another thing. So we do research, we do education, we do innovation, and we do capacity building. And we have, and this is not easy to see, but with the yellow is, I mentioned all the countries we're working in, but a lot with the Hubert Jurgen Center, we have picked 12 institutions around the world that we are really putting money into to strengthen their capacities, to do research, to do education, and to be partners with us. And that involves a whole slew of training, of IT infrastructure, of student exchange, faculty exchange, that we hope will make them stronger institutions. The 5th area is just pure technical support. Now this is what used to be done a lot more than what is done now, just the North helping the South, the rich helping the poor. We don't like to talk too much about that anymore. A lot of these innovations, as I just mentioned, are actually coming our way. Thank goodness the Kenyans are doing what they're doing, because maybe we'll learn from that someday. But there is still some of this. And the area where we're involved at the Institute is what we call we've opened up an evidence lab, and we're getting quite a lot of interest, which is providing full spectrum evaluations, formative, pre-intervention research to impact evaluation to policy recommendations using mixed methods to the various donors around the world that are supporting programs. They're often looking for someone to evaluate their program. Now, they can go to FHI or RTI, and those NGOs are very well equipped to do this. We're trying to tell them there might be some advantage. You must go through this a little bit with the CROs and DCRI. Trying to tell them there's some advantage to having these evaluations done by an academic center. Now, we have a way to go to convince them of that, and we may partner more with the NGOs that do this, but this is one area that we're trying to build up capacity, try to help in technical support. The other one, of course, is Duke Med Global, which is a very large operation that Krishna Udukayama runs. This is under the chancellor, and these are the different places in the world where Duke Med Global calls on different parts of Duke to provide technical services, training. You can see a lot of these in training courses in Kuwait, and there are a number of, particularly in China, there are some where we are providing services to different health systems and hospitals around the world. This is more in the area of business development with some profit behind it. This is what Duke Med Global does, not what the Institute does. And then the last area, which we don't do at Duke, although there's talk about it, is pure service delivery. When I first got here, there was some talk that maybe we should set up a Partners in Health at Duke, a Paul Farmer equivalent. We decided not to do that. We didn't think we had the manpower to do that. And this is you need a crazy person like Paul Farmer to do this. We didn't have a crazy person like Paul Farmer to do it. I mean, no one does it better than Paul. I mean, Partners in Health is in 9 countries now, and they just do remarkable work, and they're associated with Harvard. And there are other universities that have equivalent organizations, maybe 5. We may do this someday, but right now we're not doing anything. We certainly, our faculty provide care where they work, but it's not a formal kind of operational NGO. So I guess the final point I want to make is that how we've grown. So there were 15 faculty in the Institute when we started. And as of May 2015, we had recruited 51 new global health faculty, and there are 5 pending. So after the provost does the work, we'll have 56 new global health faculty here over a period of 9 years that have come to Duke to be part of global health. Now, what's important is 38 of these are in the schools. They're not sitting in the Institute, and 25 are in the tenure track. So this is not just all people sitting in a building. They're all over the campus. It's something I really need to emphasize. So although the Institute was given quite a bit of money to start with, it's not a secret. We were given $30 million startup, which is no longer around. We did put a lot of money into recruitments, and we did build up the faculty at this university in many of the schools. So I think it's important to know that. And with total today, we have 70 faculty members, 50 affiliates, and 19 adjunct, and I don't know, probably another 150 staff. So it's actually become quite a satisfaction to have grown it so well. And this is the distribution of the faculty. And just so that there's no doubt, I have to show this to the dean every day, but 28 of the faculty, that's still the majority, not majority, but the most number of faculty are in the School of Medicine. 17 are in the Institute. We can appoint faculty, non-tenure track faculty. We can't appoint tenure track faculty. And then 10 are in arts and sciences. That's not surprising with the major. And then we have 7 in Sanford, and then the rest are Nicholas Pratt, Fuqua, and nursing. So that's a distribution of our faculty. What are the challenges ahead? Well, I think we need to better recognize faculty engagement in global health, what that requires of them, and reward them appropriately. We work tirelessly to improve university support services for global work. I could give a separate lecture on the different support services at Duke and how they're all trying to be better. Cultivate philanthropic giving. We certainly need an endowment for the Institute. Right now, our financial model, we don't have any endowment, so we're totally dependent on core budget from the university, our master's program, and philanthropy. We need to have much greater collaborations between U.S. universities If you go to a place like Makerere University in Uganda, you'll probably see 20 US universities there. And they don't talk to each other, and they all work hard, and they all do wonderful things, but we ought to be doing more together. There are models for this, like AMPATH in Eldoret, but this is a real priority. I think we need to develop more partnerships with the US government and NGOs, and I think we need to create opportunities to share global experiences with our local communities. I think I have one more slide. Yeah, I wanted to leave you on a positive note, and that's at the Lancet 2035 report. I always tell the students, you want to read anything about global health, read the Global Health 2035 report in the Lancet. It's called Lancet Commission on Global Health. And it basically said, and by the way, the author of this, I'm delighted, will be joining Duke joining our institute in September. We've managed to get him to leave UCSF and to bring the commission here. His name is Gavin Yami, and he's a real superstar for us, a wonderful recruit. He wrote this report, and so we'll be starting a new policy wing at the Institute. But what this report says is the conclusion was that there's a grand convergence in health is achievable within our lifetime, that fiscal policies can do a lot to curb the NCDs, that we need the returns from investing in health are impressive, and progressive pathways to universal health coverage are an efficient way to achieve health and finance protection. And the report has this graph in it, which is the dream we have, which was by 2035, the countries with high mortality on the red and the ones with the lowest mortality, we would converge and have equal health in the world. If you read the Gates annual letter, which comes out every year, it's also a wonderful thing to read. Gates puts out a letter every year on the priorities in global health. The quote here is, our best bet is that the lives of people in poor countries will improve faster in the next 15 years than in any other time in our history, and their lives will improve more than anyone else's. It's just, let's hope that's true. Thank you.
Thanks, Dr. Merson. That was wonderful. Thank you so much.
Okay.
Any questions?
Mike, hi, it's Joe Rogers.
Yeah.
Thanks very much for that. I guess, the changes that you showed at the beginning of this talk in terms of the reductions in mortality of children and maternal mortality is really staggering. And even though you would argue that you didn't achieve your goals, the percent reductions were phenomenal.
Yeah.
And I think that you sort of walked us then through how you went about accomplishing that, and you deserve an amazing amount of credit for pushing this initiative at this institution. My question really was, it looked like a lot of the educational opportunities were really focused on people who live here. And I wonder, is sort of in the bigger picture of global health that we're somehow going to populate medically underserved areas with healthcare providers from more developed countries, or is the larger goal to go out and begin training people in those countries to push the public health initiative?
Sure. So, of course, your question is critical. And since we sit at a U.S. university, we have to think about sitting here about our university, right? So what is university about? It's gaining new knowledge and conveying new knowledge, and that's our faculty and our students. So we think at a university on what, first and foremost, we do for our own faculty and students. But you're absolutely right that, and I mentioned this briefly, of the 6 areas, capacity building and technical assistance, that our ultimate goal is to have our low and middle income country institutions be as self-sufficient as they can be, and have faculty and students that have faculty that can do a lot of the teaching, have faculty that can do a lot of the research. More and more grants that you get today are often the PI is from the developing country. We try to take as many students as we can from those countries here and get them to go back and not to stay. There's no doubt that your point is the key, is the future for the world's health. It's a balance on what we do as a university and what our obligations are to our own students. I would like to think that our 300 students right now in our major, and that'll probably go up to close to 400. They're going to do many things. Many of them will work abroad. Many of them will hopefully find opportunities abroad and be part of that strengthening of the world. And many of them are international students. Remember that. So I want to say I completely agree with you that we have our own obligations as a university, but those of us in the field really are committed to what you're referring to call this field international health. I have a slide I didn't show. We used to call it tropical medicine. You really have to be old to know that term. So, but the London School is still called the London School of Hygiene and Tropical Medicine. Johns Hopkins just changed the name because Bloomberg gave them $100 million. But I think they're now called the Bloomberg School of Public Health, but that wasn't their name until 10 years ago. So I think that we've seen the field move from tropical medicine, which was mostly tropics, troops in the tropics, international health, which is the rich helping the poor, global health, which is thinking of us as having common diseases and learning from each other. And that's why I talked about the New World Order. I think when you think about a country like China, I mean, go to China and go to Africa, you will see Chinese everywhere providing all kinds of assistance, healthcare, and we need to be seeing ourselves as a partner in that kind of effort. So I appreciate your comment, and it's absolutely true that the future is in strengthening our partners.
One quick question. So given the portfolio of research at the DCRI, some of it, obviously a big chunk of it is clinical trials, but a lot of it is also population-based studies,
right.
Registries, those sorts of things. Do you see some natural areas of partnerships?
Sure. I've had numerous discussions with the different directors of DCRI since I've been here. I guess there's now been 3 since I've been here. Well, that's okay. It's over 9 years. It's not bad. But the question is, where do we match? And obviously, we decided early on that we would not get into the business of clinical trials. I mean, that would be silly. I mean, we can't. You guys are the best in the world at that. And where we've always talked about overlap is on epidemiological studies, outcome studies, evaluation studies, registry studies, particularly, for example, in cancer, even heart disease. And the challenge has been coming up with the research support for that, getting faculty that can both fulfill their clinical needs or other needs here at Duke and also work overseas. We have 9 faculty that are stationed overseas. I wish we had 20 faculty working overseas. That would be ideal. And those that work overseas, it's not easy to get grants and keep their portfolios. But I think to the extent we can raise the dollars, there are a lot of opportunities. I know Eric is interested in this. I think there are just some challenges in finding the research grants, because many of you in the DCRI are either on, I don't know what percent, but high percent of soft money. And so if we're going to work abroad, we need to come up with a grant portfolio for that. Now, the good thing is we can look outside NIH now and pharma. As I mentioned, you can look to Brazil is putting a lot of money. There are a lot of other countries, I think, eventually that will put more money in. And there's also Wellcome Trust, and there are other organizations that can fund this work. But the question is, for the faculty in DCRI to get promoted in their departments and to be recognized, that's the challenge. I mean, Cynthia's worked on this a lot from the Hubert Jurgen standpoint. I'm grateful for what we're able to do, but I think it comes down in the end to having the faculty. And I think DCRI as an organization has been committed if we can find the mechanisms and the funding and the faculty to do it. Is that fair, Cynthia? So Joe, we should discuss that we are going to discuss it from the cardiology standpoint, because that's the other thing. DCRI is integrated with a division of cardiology, the Department of Medicine. You're not easy, we have some flexibility because we report directly to the provost and chancellor. So we have less, I'll use the term bureaucracy perhaps, less, I don't want to say oversight, but we're more flexible, let me put it that way. We have more flexibility with our funds. We don't get any indirects though, just so you know that. We don't get one dime of indirects. We have a business office that handles $25 million worth of grants a year, and we don't see any of the indirects. The indirects go to the home department or the PI. So, and unfortunately, a chunk to the medical school. So, which I can't so far been able to control. Okay?
Thanks for
Sure.
phenomenal
Thank you very
presentation.
much.
Thank you.